scary start to the movie. So we're getting to the better parts, what we can do and what changes are ahead, where the research is going, and why we're so optimistic. And why is it that I'm in this field? Because I think that the pain and suffering that goes on and people who are suffering from Alzheimer's is much more important than any other disease in the sense that it's let me give you an example. Some of you here have experienced this, some of you guys are going through this right now. And the point of this is not to make you sad, it is to give you the weight of this disease. Husband and wife for 50 years came to me. The husband is a professor, quite stoic, probably never didn't quite as much in his life. Comes to me and he turns to me and starts crying. And he says, and Sergio has heard this story before, but it was the thing that actually pushed me towards this field. And he starts crying and he says, the saddest moment of my life, even though he had a pretty hard life, he had lost family members in the war, was when my wife turned to me in the morning and said, "Who are you?" A wife of 60 years. I think that pain is more devastating than any other pain. That's why we're here to fight for this disease. I don't mean to make this into an infomercial or a pep talk, but having said that, there's great hope in the horizon. So, I could go on through this. That sentence is wrong. It doesn't mean there's a good chance you're going to have Alzheimer's. Diabetes has been associated with a higher risk of Alzheimer's. But just because you have diabetes, it doesn't mean you will have Alzheimer's. In fact, those who have good control over their diabetes should not have any effect on the disease. So it's the level of control of the diabetes that matters. Yes? Yes. So there is a genetic association. The picture, as we go on, I'll show you a little more. The picture is still not completely clear. At this point, we believe about 10% of Alzheimer's is genetically related. But we think that in reality, all diseases have a genetic component. We know that because we're genetic beings. But as opposed to certain diseases like Huntington's, that if your father had the disease, you will get the disease, 100%. In Alzheimer's, the genetics seems to be more affected more by environment and lifestyle and other factors that we haven't figured out. Now, if somebody has a very strong family history, then there's a good chance that they will get it. We're talking about several family members, close family members, that have had the disease. Does that help?
Can we get the questions asked by microphone so everybody can hear the question? I'll run over the mic and we can get this question.
If I was doing this right, if my memory was working, I should just repeat the questions.
You have a question?
I saw that Hashimoto's thyroiditis.
Yes.
Autoimmune disease runs in my family. My daughter has Graves' disease. I have Hashimoto's. And I've heard that the numbers that you should have for medication, your thyroid medication, are different than what you're hearing. What is it about that relates to Alzheimer's?
And so far what we know is that in thyroid disease and diabetes and other endocrine diseases, it's the lack of control that gives you a higher rate of developing the disease, not so much having the disease itself. So far, that's all we know. So if anybody says anything more than that, they're overstating the data. Within the numbers that have been studied so far. Now, that doesn't mean that that's the truth. That's the truth we know right now. Yeah. No problem. We have a question right here.
The disease of Alzheimer's itself is an effect an ethnic group predominantly? Or?
Yes. So the latest data, again, when we're talking about data, especially epidemiological data, we have to make sure that we don't overstate. In anything, in science, it's very hard to make cause and effect relationship and make direct causation. So in everything that we hear has to be reviewed with several times before we say, okay, this is it. But the latest data shows that Hispanics and African Americans are, even after you control for age, gender, education, and lifestyle, they're 1.7 to 2 times more at risk for dementia. But sadly, for example, my clinic, I see 1,000 patients with dementia, but only 15 SAMs. So the information is not out there. That's part of my talk, that not just in SAMs, in all the communities, the information is not out there as far as what this disease is, what the early signs are, and what should be done, especially in the minority population. The ones that are most at risk are least aware of it. So that's what we're doing. One of the things we're doing is actually that kind of research, and that kind of information this kind of distribution. I'll just see this. So we're talking about the tangles and plaques. So this is what happens to amyloid. That's one of the proteins that some of you have heard over and over again. For the last 10 to 15 years, everybody's been focusing on this protein. It's actually the precursor of what this disease starts with, or this protein starts with, is actually a normal part of the cell. This is the amyloid precursor protein, which is a normal part of a neuron cell. But what happens, they're cut in the wrong place. Something happens that the enzymes cut them in the wrong place, and the byproduct actually accumulates into plaques, and they cause obstruction of communication and cell death. And this is where the research is actually focused on right now, seeing how to take away these plaques. That's where the immune research is coming in, which I'll talk about later, and help stop these enzymes, beta secretases and gamma secretases. Some of the studies were not successful, but we're still in the process of figuring out how to stop these to see if that would change the course. Another little caveat to this is that we're not even sure if this is the disease process altogether. Still, a lot of information needs to be gathered. So it's not clear as people try to make it out. Another thing that happens is tangles. What you see here, these are microtubules. Inside of every cell, there are these structures, support structures, like support beams. It's an amazing system that actually support the cell. Now, connected to these are, we have tau proteins. And what happens is these tau proteins are phosphorylated and they come off. We don't know why. We know the process. We know what happens, what happens ultimately. But why does it happen? And what influences that, we don't know. And that's where the research is getting interested. And once they come off, they clump into tangles, and they are the cause of destruction of communication within cells and cell deaths from within. And again, this is a normal brain, and the tissue under the microscope of a normal brain, and this is the Alzheimer's brain, and the tissue under the microscope of that Alzheimer's brain. This is a normal brain volume, and this is the advanced Alzheimer's brain volume. You can see the stark difference involved. Genetics. We're talking about genetics earlier. So one of the genetic factors that's been shown to be associated with Alzheimer's is ApoE4. Ironically, ApoE4 is a gene that deals with lipids and transport of lipids. And there are several types of them: ApoE2, ApoE3, ApoE4. Those who have ApoE2 have a protective component. They're less likely to develop Alzheimer's. Now, these numbers are not 100% zero. If you have APOE2, you can still develop Alzheimer's, but much less frequently. Now, if you have APOE4, it's 4 times as likely to get Alzheimer's. In fact, 40% of those with Alzheimer's have APOE4 gene. Some of the other genetic links that I've made so far, especially in early Alzheimer's, are presenilin-1 and presenilin-2, and amyloid precursor protein, and some others that we see here. But we think for the rest of the Alzheimer's diseases, they are genetic as well, but they are multi-genetic. That means multiple genes come together to give the final disease. And it's the influence of environment and lifestyle that affects the manifestation on how that disease, that those genes actually express themselves. So this is where the lifestyle research is so important. Warning signs of dementia and early cognitive decline. Memory changes that disrupt daily life. This is the kind of stuff that I want to dispense among the population. Not to scare them. I mean, just because you forget, somebody's name, I forget all the time. Just because you forget some, directions or you get interrupted in the content, that doesn't mean it's a problem. But if they have it in constellation and much more frequently than your baseline, that's a sign that these get checked. Challenge in planning or solving problems. Difficult completing familiar tasks, things that they could do easily before. Confusion with time or space or place. Trouble understanding visual images and spatial relationships. Those with mild cognitive impairment are at much higher risk of falling than even Parkinson's patients. That's an amazing fact. New problems with words. Their vocabulary was immaculate before this, and now they're having difficulty finding words that they were easy to find before. Misplacing things and losing things, difficulty to trace steps, decrease in poor judgment, withdrawal from work and social activities, and changes in mood and personality. Now, again, all of us have some of these, and can be several of them. It's not the fact that they have these, but they're happening at much greater rate than would be expected for that person 5 years before. Some of the treatments, now the word treatment is a misnomer here. It's an overstatement. Of course, by some definition, it's a treatment, but it's an overstatement. I want to make sure that when you go to your doctor, you don't get a false sense of security when they give you a little Aricept or this or that. The drugs are marginal. I have some of my patients here. The drugs are marginal. I don't deal with drug sensation. It's me identifying the problems, other problems I'm dealing with, which I'll talk about. But the drugs that we do have fall into 2 categories. They are cholinesterase inhibitors and NMDA receptor antagonists. Under cholinesterase inhibitors, you have venetoclax combined with Aricept, Riverside, Exelon, and we have a patch form of that, and we have glycine, which is Resna. And the NMDA receptor antagonist is Nemenda. So they are cholinesterase inhibitors. They increase the level of acetylcholine. Acetylcholine is one of the most common neurotransmitters in the brain, and it's the neurotransmitter that's affected in this disease. So what we do is, we use cholinesterase inhibitors to stop the breakdown of acetylcholine to get more of it. As opposed to, and again, what we used to do was give acetylcholine. Well, acetylcholine going throughout the body, you're going to have severe diarrhea, nausea, and GI symptoms. But by using the body's own acetylcholine, meaning that the acetylcholine is released